Hi, Dr. Debdeep, all ready? Hello? 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 Hello?
Hello, can you hear me now?
Yeah, I can hear you. You ready?
Yeah, I'm ready, yes.
Let's start?
Yes, please.
Right, so let's start, right. Good evening, everybody. Welcome to this evening episode of Pursue, and this is Pursue 2E, Lymphnodal Pathology, and we are streaming live from Kolkata, India. And we have a very special topic today, which is many phases of extranodal lymphoma, a hot topic. And to talk on that, we have Dr. Debdeep Dey, who's an FRC Path with CCT from UK. He's a consultant oncopathologist at Tata Medical Center, Kolkata, an expert in lymphnodal pathology. Before I ask Dr. Dey to take over, let me request all of you to please keep your mic muted, your camera off, and please do not share your screen. With this, let me request Dr. Dey, sir, please share your screen and start. Just press present now on the right side of your screen and your entire screen and the center of the screen and share. Yeah, we can see your screen. Yeah, just please make it full screen. Yeah.
Is it okay now?
Yeah, you can just press that hide pop up so that it just goes away. Fantastic. Please start.
Good evening, everybody. Thank you, Dr. Nadeem, for the opportunity to present this topic. Today, I'll be discussing the many phases of extranodal lymphoma. I have been presenting a few lectures about high-grade B and low-grade B, and today I thought I'll discuss some of these salient entities in extranodal lymphoma. So, as the name implies, extranodal lymphoma is a lymphoma which arising from a non-lymphnodal tissue, which means that it is not in the lymph node, spleen, or the bone marrow. So, approximately 1/3 of NHL will arise from sites other than the lymph node, spleen, or bone marrow, and even from sites which normally do not contain any native lymphoid tissue. It encompasses a vast assortment of morphologies, molecular alterations, and clinical presentations. And I like to emphasize this fact that the clinical presentations can be varied, and therefore lymphoma is sometimes not suspected clinically, or even even when the slide comes to us. Therefore, it is incumbent on us to be aware of the suspicion that a lymphoma can arise at almost at any site in the body. Correct diagnosis and appropriate treatment of extranodal lymphoma is often complicated by the variety of lymphoma types and the relative rarity of many of these tumor types. So what are the risk factors of lymphoma? So one of them is pretty common. Almost all of us have seen something like this as the gastric marginal zone lymphoma, which is due to Helicobacter pylori or Helicobacter hellmann infection. So, and from there we go to the weird and the wonderful, which is the Campylobacter jejuni or Borrelia burgdorferi. This is responsible for immunoproliferative small intestinal disease, which is a disease not found in our part of the world, mainly in the Middle East, Asia. It's more common. Chlamydia psittaci can cause orbital or ocular adnexal marginal zone lymphoma. Autoimmune disease like Sjogren's syndrome, SLE, can also result in this. So there's a spectrum of changes from lymphoepithelial lesion to Sjogren to SLE, where in the background of which an MZL can arise. Celiac disease, again, not very prevalent in our part of the world, but very common in the Western world, which can cause enteropathy associated T-cell lymphoma, HIV/AIDS, organ transplant, which can result in a post-transplant lymphoproliferative disease, hepatitis C virus, long-standing chronic inflammation, breast implants, and Hashimoto's thyroiditis. So this is a very long list of risk factors associated with marginal zone lymphoma. Like with everything else in the body, there is everything else in lymphoma world. You have the B cell lineage and the T cell lineage, and there is also the NK cell lineage. But Hodgkin lymphoma in an extranodal site is extremely rare, and therefore be very cautious when you diagnose a Hodgkin lymphoma in an extranodal setting. Although you can see sometimes in the GI tract as well as in the spinal area. So DLBCL, the diffuse large B cell lymphoma, no different from what you get in the lymph node. It's the most common extranodal lymphoma. Almost all lymphomas are DLBCL in the central nervous system, testis, bone, and paranasal sinuses. It is also common among lymphomas of GI tract, Walder's ring, breast, and skin. Adults are most often affected. Children and young adults can also be affected. It is characterized by sheets of centroblasts, immunoblasts, and large bizarre cells, as you could see in DLBCL. Outcome overall better than a primary nodal DLBCL, much better for GI system and bone, and worse for CNS and testicular primaries. So I'll just show you a case. This is a case of a 48-year-old man presented with a headache, a cerebral lesion. As you can see, sheets of lymphoid cells, and at high power, these cells have lymphoblast-like morphology with very scanty cytoplasm, as well as high NC ratio, lot of mitotic figures, and and when you do the immunostains, it's CD20 positive, CD5 positive. So some people start their IHC panel with CD20 and CD5. That helps us to diagnose mantle cell lymphoma quickly. And it's positive for cyclin D1, Ki67, and SOX11. So this is a very unusual and a very rare case of blastoid mantle cell lymphoma in the CNS. So it's just if you're trying to be aware of the entities that can happen, and doing a thorough immunohistochemical workup. If you are working in a center which does not have immunohistochemistry, it is useful that you don't sort of try a heroic diagnosis. You just call it a lymphoproliferative disorder and send it to a higher center which has got all the facilities of it. So the next case is of a 74-year-old woman, a resident of Bhutan, transferred to our hospital, the Tata Medical Center. This presents with the pancytopenia and coagulopathy and hypoalbuminemia. Now, the reason for me saying all these investigations is the almost total unsuspecting nature of a lymphoma and the varied clinical manifestations. This one, I remember this case presenting to us with a diagnosis of a clinically suspicion of cirrhosis of liver or some sort of a chronic liver disease. There is pancytopenia, there is coagulopathy to an extent that liver biopsy was not possible. CT scan showed hepatosplenomegaly, splenic infarct, and dilated portal vein with splenic collaterals, and PET CT scan showing a large spleen with diffusely increased metabolic activity. Now, because of the coagulopathy, it was not possible to do a liver biopsy. A splenic biopsy is just out of question. Therefore, a transjugular liver biopsy was done, and with showed this picture of a liver biopsy which dilated sinusoids, and you can see these large cells here with pleomorphic nuclei, which is staining positive with CD20, highlighting the scattered cells within the sinusoids, very large size, which are BCL2 positive and with a high Ki67. Bone marrow examination was done, which did not show any abnormal cells, showed a trilineage hematopoiesis, but a cytogenetic analysis showed a complex karyotype, which is mostly associated with high-risk myeloid neoplasm. So we have a intrasinusoidal large B cells which are positive for 20 BCL6 and MOM1 with a high Ki67 and negative for all these markers. So a diagnosis of an intravascular large B-cell lymphoma with background non-alcoholic steatosis without cirrhosis was made. And the patient was started on our mini-CHOP protocol, and the patient responded, and 1 year later, she is fine and with resolution of most of the symptoms. So the index of suspicion was not at all on lymphoma. There was no lymphadenopathy. It was a liver biopsy done with the aim of diagnosing a liver disease, but yet it showed that this is an intravascular large B-cell lymphoma. So this is another example of brain in which the arteries or the vessels are clogged with these large cells. It's CD20 positive, and therefore it's a intravascular large B-cell lymphoma in the CNS. It is characterized by this proliferation of the large lymphoid cells within the lumen of blood vessels. And because of the relatively non-specific symptoms and extranodal presentation and the rarity of the disease, this is a challenging diagnosis to make. Further, it is compounded by the fact that there is no definite organ to biopsy. So there are two different types of clinical presentations. One is the Caucasian patients, which presents with skin and neurological symptoms, as I showed you in that brain biopsy. And the other one is a Asian patient. So our patient was Asian, presented with hepatosplenomegaly, with involvement of the liver and the spleen, but no involvement of bone marrow. But Caucasian patients presents with skin and neurological symptoms, and they are confined to the dermis and subcutis at presentation, and it has got a better prognosis. So this is a case of a pleural fluid. As you can see, large cells with immunoblastic and plasmablastic cells, and the cell block showing large number of apoptotic bodies. And when you do your CD20, cytokeratin, melanine, all are negative. CD3 staining the odd background reactive T lymphocytes. CD30 staining occasional cells, but MOM1 is positive. So is HHV8. So this is a primary effusion lymphoma. Now this is also on one of the lymphomas which is unsuspecting clinically and therefore may cause a problem with the diagnosis. So you have to sort of keep in mind that this is a type of lymphoma which can occur in cavitary markers to arrive at a diagnosis. The next case is a 13-year-old boy from Bihar, presented with intermittent pain, abdomen and vomiting and weight loss. Endoscopic guided biopsy was done and biopsy from the duodenal polyp was done. So what we have got is this very ulcerated nodular polypoid area. As you can see, sheets of cells with almost like a starry sky pattern here, diagnosed outside very rightly as very obviously as a high-grade B-cell lymphoma favoring Burkitt lymphoma with a starry sky pattern. But the important thing was the CD20 was negative in this one. So more high-power pictures showing a very vesicular pleomorphic nuclei with prominent nucleoli, some cells looking very plasmacytoid with numerous mitotic figures in this here. And when we did the markers, it was CK negative, CD20 negative, CD3 negative, and PAX5. So whenever you think that this is a lymphoma and there is all these markers are negative, then you should start thinking about other things like myeloid sarcoma, like plasmablastic lymphoma. So you can do a CD45, but we sort of thought that we start with MUM1. The MUM1 is positive. Now, MUM1 is a plasma cell marker. It can also be positive in B cell lymphomas of the post-germinal center type and a high Ki67 of more than 90%. CD10 is positive, and which sort of also gives us an indication that you might be dealing with a plasmablastic lymphoma, because CD10 is unusual in a plasma cell neoplasm with a plasmablastic morphology. So MUM1 can also be positive in a plasma cell neoplasm, but a 13-year-old boy with a duodenal polyp, it's unlikely to have a plasma cell neoplasm. CD138 strongly positive, and therefore, and kappa showed light chain restriction. Iberish is positive, so it's a plasmablastic lymphoma. Now, plasmablastic lymphomas most often occurs in immunosuppressed patients. This patient was not immunosuppressed but was suffering from hepatitis B. It's present predominantly in the oral cavity, GI tract, and the lymph nodes. And as I said, the morphology is of sheets of plasmacytoid immunoblasts, some with very obvious plasmacytic differentiation. Iberish is positive in 60 to 75% cases. HHV8 is negative. This is how you rule out a primary effusion lymphoma if the patient has presented with pleural effusion. And overall, it has got a very poor prognosis. But the important thing is the DDs is a DLBCL with a plasmacytic differentiation, a plasma cell neoplasm, and non-hematologic neoplasms. Now, this is a very old paper from 2005. It sort of drives home the point that plasmablastic lymphoma and plasmablastic plasma cell myelomas have nearly identical immunophenotypic profiles, and it is only Iberish that is able to differentiate between the two. But Iberish is only positive in between 60 to 86% of the cases, and therefore, in the or 20 to 30, 40% of the cases, you might get an identical immunophenotype. And there, your clinical pathological correlation sort of helps you in making the diagnosis. This is because a plasma cell myeloma will present with bone lesions, whereas a plasmablastic lymphoma will present with lymph nodes and other clinical and biochemical characters of myeloma will be present. DLBCL associated with chronic inflammation is another entity where a long-standing chronic inflammation in a closed space can result from present for more than 10 years, can result in a DLBCL. You have associations with osteomyelitis, venous ulcer, metal implant, iatrogenic pneumothorax for TB. Other associations are atrial myxoma. I've seen only one case of that, cardiac replacement valves, and long-standing hydrocele. So we've sort of touched upon the high-grade B-cell lymphomas among the extranodal lymphomas. Now we go into the low-grade B-cell lymphomas. So the MALT lymphomas are the very common of these low-grade B-cell lymphomas. It usually happens in the adults, usually the middle-aged or the older patients. It happens in GI tract or ocular adnexa, salivary glands, intestine, breast, thyroid, lung, skin. You almost name it, and any organ you can have an yes there. Male to female ratio varies by site. It is usually localized, stage 1 or 2, and It is normally indolent, sometimes even treated by local therapy such as antibiotics, as in Helicobacter pylori-induced marginal zone lymphoma. It is a very good prognosis, however, if it may undergo large cell transformation. So this is the case of a gastric biopsy, 54-year-old male. So you can see a very nice reactive follicle here surrounded by these mantle cells, and then there is this the marginal zone proliferation of small cells with a monocytoid appearance, and which sort of infiltrating into the crypts. And this is one of the cases in which, and this is the same case in which the lymphocytes are going into the epithelium, resulting in so-called lymphoepithelial lesions. So these are the different phases of MALT lymphoma. This is from this paper in January 2020. So you have the classical monocytoid appearance. Then you have got this C is this clear cell variant. Then you have got, this is what is called the lymphoplasmacytoid appearance. You can see lymphocytes and plasma cells, which brings in the differential diagnosis of a lymphoplasmacytic lymphoma. Then you have got a prominent plasma cell differentiation with the Dutcher bodies, as you can see here, these intranuclear inclusions. And when you get to plasma cell differentiation, the other thing that comes here is a plasma cell neoplasm involving an extranodal site. Then there is this classical lymphoepithelial lesions. This is in a MALT lymphoma, however, this is in a follicular lymphoma. So lymphoepithelial lesions can also be found in follicular lymphoma, in mantle cell lymphoma. So it is not criteria to diagnose marginal zone lymphoma, but it does help in establishing the neoplastic B-cell process. This is a very classical picture of a CD20 population. This is a crypt which is getting infiltrated by this CD20 positive cells, resulting in the classical lymphoepithelial lesions. As you can see, the same area in which there are very negligible amounts of CD3. And this is the cytokeratin highlighting the crypts, and the CD20 positive cells are sort of, as you can see, being punctuated by the CD20 positive B cells. And CD43, it is only one of the markers which only comes in about 50% of marginal zone lymphoma cases, and CD43 is positive within the CD20 positive population. Therefore, one has to understand that there is no specific marker for marginal zone lymphoma. You diagnose marginal zone lymphoma by a CD20 and BCL2 positive population, with an exclusion of follicular lymphoma by doing your BCL2, BCL6, CD10, by doing your CD5 cyclin D1 by excluding mantle cell lymphoma, and CLL by doing CD5 and CD23. Next, we come into the mantle cell lymphoma. It is present in older adults with a male preponderance. Widespread disease, it presents with a widespread disease in both lymph nodes and extranodal sites. In extranodal sites, it mainly presents in the form of multiple lymphomatous polyposis. Other sites which get involved are Walde's ring, orbit, and skin. It has got a more extensive disease is usually present. So this is a case in the GI tract. I thank Professor Judith Ferry of Mass General Hospital for the slides. So this is the classical reactive follicles here, and then there is this monotonous population of this cells which on high power shows irregular nucleus with inconspicuous or variably conspicuous nucleoli. And when you do your markers, it is positive for cyclin D1, as you can see, CD21 highlighting the dendritic cell meshwork. The BCL6 is positive within the residual follicle, and the BCL2 is negative within the follicle, but it's positive within outside the follicle, that is the mantle zone proliferating mantle zone cells. So you have to sort of see where your follicle is and whether it's BCL2 negative or it's BCL2 positive. If it is a BCL2 positive cells with the CD20 predominant population, you are justified in calling it a low-grade B-cell lymphoma. Now, there are different cytological variations. We have got the classical mantle cell lymphoma, which I described, the aggressive variant, which is the blastoid, and the pleomorphic variant. The blastoid variant, as I showed you in the CNS case, is can be mistaken for a lymphoblastic lymphoma. So you have to do your TDT, CD10, as well as your cyclin D1. The pleomorphic variant can be mistaken for a DLBCL. Therefore, you have to do your cyclin D1 and SOX11. Remember, DLBCLs can also have cyclin D1 positivity. Therefore, it is imperative that you also do this SOX11, and in more difficult cases, you can always do the FISH. Other variants which are not that clinically significant are the small cell variant and the marginal zone like variation. So this is a skin biopsy of a 60-year-old male. I've put a scanning low power photo just to highlight the fact that how subtle the lymphoid infiltrate can be. So when you get a skin biopsy and you're thinking that it could be a lymphoid process, and in skin you may have a lot of reactive infiltrates like Jester's lymphocytic infiltrate, which can mimic RA. But the thing in this case is that it is a very deep dermal lesion. It's going into the fat, and there is no involvement of the epidermis or the upper dermis, which is where most of the reactive infiltrates sort of are present. So at high power, this is your atretic germinal center surrounded by this proliferation of small size B cells with inconspicuous nucleoli. When you do your brown stents, you see the CD20. This is your darkly stained atretic germinal center surrounded by this proliferation of marginal zone cells. So you've got a BCL2 which is negative within your atretic germinal center and positive within the CD20 positive population. The BCL6 highlighting the residual atrophied or atretic germinal center. It is negative in the outside CD20 positive population, thereby helping us to rule out follicular lymphoma. And the CD3 and quite present in predominant numbers, but what tilted the balance was this kappa and lambda, which showed a light chain restriction here, and thereby the combination of CD20 BCL2 along with kappa lambda restriction is sort of confirmatory of a marginal zone lymphoma. So what are the differential diagnoses? As you can see, if there is a subtle lymphoid infiltrate, a chronic inflammatory process always comes into the picture. And other small B-cell lymphomas, we have the mantle cell, the follicular lymphoma, the lymphoplasmacytic lymphoma. Mantle and follicular are very easy to differentiate because of the fact that mantle cell lymphoma will have CD5, cyclin D1 and SOX11 positivity, while follicular lymphoma will have CD10, BCL2 and BCL6 positivity. The real problem is a MALT versus a lymphoplasmacytic lymphoma. There's significant degree of overlap, and if there is marrow involvement, if there is a large IgM component, and if there's a mid-88 mutation, that helps in favor of a LBL. But in certain cases, it is not possible to have all this information when you are actually authorizing the report. So you can say that this is a low-grade B-cell lymphoma, and the disease is between a marginal zone versus a lymphoplasmacytic lymphoma, and suggests to do all these tests. Now, the more difficult problem which I find in routine practice is the distinction between a marginal zone lymphoma versus a marginal zone hyperplasia. Now, a marginal zone lymphoma has got more cytological atypia with an expansile destructive infiltrate, lymphoepithelial lesions, a diffuse CD20 positive population of cells, which is clonal, and there is co-expression of CD43 in the CD20 positive population. Now, it is all good to list down these points, but when it comes to actually making the diagnosis on the slide, not all the features will be present. Therefore, you have to sort of look at the case in totality, and you sort of balance how many points are for and how many points are against, and then make up a mind. But sometimes it is not possible to do, and you sort of end up calling it an atypical marginal zone proliferation. You can ask for clonality, or you can ask for a repeat biopsy, or you, because it's a low-grade lymphoma, you can allow the patient to come back after certain time, and thereby sort of allow the disease to manifest itself on a larger scale, in which diagnosis may be easier. Now, this is the skin biopsy. As you can see, there's no problem with the diagnosis that there's a lymphoid process going on. We have got a pandermal infiltrate, which is separated from the epidermis. This is the epidermis. This is the pandermal infiltrate, which is separated by this prominent Gren zone. So whenever there's a Gren zone, you sort of start thinking on the lines of a B-cell lymphoma. So you have this very extensive, dense lymphoid infiltrate composed of this coalescing follicles at high power. The follicles are without polarization, polarization zone. There's no tingible body macrophages. And when you do your markers, the CD20 highlighting the follicles, the CD10 is positive, the 21 highlighting the dendritic cell meshwork, the CD3 showing the background reactivity lymphocytes, and you always think there's still quite a large number of CD3 positive cells, and there will be, that's part of the immunogenic mechanism. The BCL6 is positive, but as you can look here, the BCL2 is negative. So you always sort of compare your BCL2 with your CD3, because follicular T cells can also stain up with your CD20. So when you compare this picture of CD20 with the BCL2, you can see that there is much loss or almost negligible amount of CD20 expressing BCL2. And this is quite a common feature in cutaneous follicular lymphoma. So, and this should not sort of prevent you from making the diagnosis of a follicular lymphoma. So it occurs in middle-aged adults and presents with red, violaceous plaques, nodules, and predominantly present in tumors of head, neck, and trunk, composed of small and large centrocytes and centroblasts. The pattern might be follicular or diffuse, or only diffuse. And when it is only diffuse, and the differential diagnosis comes in with a DLBCL. And the BCLs will be CD20 positive, BCL6 positive, and CD10 mostly are positive, but BCL2 may be negative. And admixed T cells may be abundant, as you saw in the previous picture, and this has got an excellent prognosis. So now we come to we've done the high grade B, the low grade Bs that are mostly happens in the MALT lymphomas. Now we come to the varied presentations of a T cell lymphoma. So this is a 50-year-old woman, history of mastectomy for breast cancer, IDC grade 3, reconstruction with the breast implant, now the complaining of fluid around implant with loosening of implant. Now, again, as you can see, so if you don't know this entity, you would be sort of quickly passing your slides without even thinking that there's an entity like this, and there's a possibility of a lymphoma here. So this is the capsule of the surrounding the implant. As you can see here, there is this fibrin, hemorrhage, and these sort of atypical lymphoid cells here. And not much, but it's still there. But the fluid actually showed a lot of large lymphoid cells with numerous mitotic figures, some of them multinuclear cells with prominent nucleoli. And it is positive for CD30, CD2, CD4, CD43, but negative for CD3 and ALK1. So if you do your CD20 and CD3, both will be negative, and then you have to sort of expand your T cell lymphoma panel to get to the diagnosis. So this is an ALK negative ALCL, and this is a provisional entity which is called the breast implant associated ALCL. It can be after cosmetic or reconstruction after cancer, and it is almost always unilateral. And it mainly presents as a seroma and not a mass lesion in most. It has got a very good prognosis if it's localized disease, but if it forms a mass or it spreads beyond the breast tissue, has got a poor prognosis. And it's CD30 positive, ALK1 negative, it's CD43 positive, and CD4 positive, with EMO positive and loss of one or more pan T cell antigens. Clonal TCR genes. The next we come into this folliculotropic MF. Now, I've sort of picked on this one because, again, sometimes this is notoriously mistaken for a folliculitis or follicular mucinosis. So it's important to know about this entity, more so because it has got a very aggressive prognosis. So you've got these two hair follicles, which is showing a very dense lymphoid infiltrate, but there is no epidermotropism. The epidermis is completely spared. More of these atypical lymphoid cells infiltrating into the epidermis. At high power, the lymphoid cells are irregular, have irregular hyperchromatic nuclei, some in the dermis. So you sort of have to pick it up on morphology that something is not right here. And then you do your Alcian blue, which is showing the mucin. Then there is the CD3 positivity with a few scattered CD20 positive cells. There is partial loss of CD7, then CD4 is positive, and then there is some loss of CD8. So this is a folliculotropic mycosis fungoides, and it differs from the classical form of mycosis fungoides by presence of folliculotropic infiltrates and with sparing of epidermis. So if you are thinking of mycosis fungoides as always involving the epidermis, you might be mistaken. It mainly occurs in the skin lesions in head and neck region and presence of grouped follicular papules, acneiform lesions, and associated alopecia are the other presenting features. It is important to diagnose this because it is more aggressive than the classical mycosis fungoides. Next, we come into the enteropathy type T cell lymphoma, formerly called the EATL type 1. If you're practicing in India, you may not get this disease because it presents mainly in the Western population with evidence of celiac disease, but many may not have any history. More importantly, it presents with very non-specific symptoms of abdominal pain, diarrhea, nausea, vomiting. So, and it mainly presents in the jejunum with multifocal ulceration, with or without perforation or mass. Now, the general history that you will be provided is that patient presented to the emergency with abdominal pain and the patient is perforated. So the surgeon has gone in and taken out the segmented intestine. So there's no preoperative diagnosis made. So you have to sort of look at your perforated intestines, gangrenous intestines, especially from this area surrounding the perforation to see if there is any evidence of this lymphoma. The cell of origin is the intraepithelial T lymphocyte. Again, it has got a very bad prognosis, mainly because the malnourished patients cannot tolerate chemo, and patients always present in a very bad condition with perforation and extranodal spread. Many cases could be prevented with gluten-free diet. So this is a case of small intestine with a diffuse infiltrate, very pleomorphic looking large cells with these eosinophils here and there, irregular nucleoli. It's positive for CD3, perforin, which is a cytotoxic marker. Occasional cells are CD30 positive, and it's CD5 negative. Now, always look at the adjacent villi. So you can see here there is crypt hyperplasia, there is increased intraepithelial lymphocytes, very nicely picked up by the CD3 stain. But in addition to the intraepithelial T lymphocyte, there will be villus atrophy, as you can see here. And there will be crypt hyperplasia, and there will be a lot of inflammatory infiltrate. There's lymphocytes, plasma cells here. So villus atrophy, crypt hyperplasia, chronic inflammation, and intraepithelial lymphocyte. All these four will be present in the celiac disease, which happens in the adjacent areas of this enteropathy type T-cell lymphoma. Now, type 2 refractory celiac disease is a DD of this EATL. It presents with villus atrophy and intraepithelial expansion of slightly atypical lymphocytes, which are usually monoclonal with an aberrant immunophenotype. It can also show loss of CD3 expression and loss of CD4 and CD8. It is actually an in situ precursor to EATL. However, it lacks the inflammatory background, the predominant large cell morphology, and infiltration with possible mass formation, necrosis, or angioinvasion, as you can see in EATL. The other differential diagnosis is ALCL. Here CD7 will help, because CD7 is normally negative in EATL, but it can be positive in ALCL. Of course, CD30 helps, but sometimes EATL can also present with CD30 positivity. The next is this monomorphic epitheliotropic intestinal T-cell lymphoma, MEITL, which was previously called as EATL type 2. Now, in contrast to EATL type 1, or in contrast to EATL, MEITL has a lack of association with celiac disease, predominantly occurs in the Asians, and monotonous infiltrate of small to medium-sized neoplastic cells. There's no prominent inflammatory infiltrate, as you saw in this previous example, and there would not be villus atrophy. There will be absence of necrosis, except necrosis may be present in the superficial area, but not a transmural. And it is characterized by CD3, CD5 negative, 8 positive, and 56 is also positive. And your prognosis is poor, and dissemination to regional lymph nodes, mesentery, pancreas, pelvic organs, lungs, or brain may be occurring. So this is again an example of this small intestine ulcerated lesion with a diffuse transmural infiltrate of monotonous looking small lymphocytes. More of that. Occasional eosinophils are there, and it is positive for CD3, CD8, CD56, negative for CD5. So to summarize the differences, EATL has got a strong association with celiac disease, mainly present in Europe. Association with celiac disease, mainly present in Asia. It presents mainly in the small intestine, but colon and stomach may also be affected, but small intestine is affected mainly in MEITL. Ulceration, stricture, tumor mass, all can be present in both. And this is where the problem is. That if you do not know of the entity, or if you're not thinking when your gangrenous intestines come as part of your emergency laparotomy, you are not suspecting it. So this is where you have to suspect that, am I not missing a MEITL in this part of the world, or a EATL in UK or the Western world? The other differentiating points are pleomorphic cells present with angioinvasion in the EATL and monomorphic cells present in MEITL. Villus atrophy, crypt hyperplasia, increased IAL all will be present in EATL but not in MEITL. You may have some increased IAL, or that is intraepithelial lymphocyte, but not villus atrophy. With regards to the immunophenotype, CD237 are positive in both them, CD45 negative in both of them. The differentiating would be CD8 and CD56. And if CD30 is negative, CD30 comes positive, then it helps to diagnose EATL because mostly MEITL will be CD30 negative. This is another case of a 20-year-old man, nasal mass, and as you can see here, this is a very necrotic ulcer slough, but if you look hard enough here, you've got these cells with irregular medium to large size nuclei with mitosis. It is CD3 positive, it is CD20 negative. Granzyme is positive and so is Eber-ish. So it's an extranodal NK T-cell lymphoma nasal type. It's a very aggressive lymphoma. Adults are mainly affected and rarely children may also be affected. Destructive nasal or midfacial tumor. Other sites such as the non-nasal upper respiratory tract sites such as larynx may also be infiltrated. Skin, GI tract, testes, all can be infected. It is characterized by angiocentricity and angiodestruction. Cells may be small or medium-sized, irregular, uniform or pleomorphic, or large or bizarre cells. Most cells have NK cell origin, with the minority have T cell with cytotoxic phenotype. It is positive for CD3, CD56, perforin, TIA1, granzyme B, and it's EBV positive, and it has got a poor prognosis. Good prognosis with low stage and radiotherapy. But the differential diagnosis is what is very important here. An inflammatory process. You may look at low power and see there is necrosis, there is ulcer slough. I will not go down, and you will miss the neoplastic cells, because this extensive necrosis with the ulcer slough and the necroinflammatory infiltrate will obscure the neoplastic cells. Therefore, you might be missing this process. Wegener's granulomatosis. Vascular involvement is a feature which can be seen in both extranodal NK T-cell lymphoma and with Wegener's granulomatosis. Therefore, and it also happens in the upper aerodigestive tract. Therefore, you have to be very careful about this Wegener's granulomatosis. Sometimes, if you have the overlying epithelium, they will show a marked pseudoepitheliomatous hyperplasia to the point that you will call it a squamous cell carcinoma, and thereby that again the treatment will markedly vary. Therefore, see, all these processes is sort of almost like a H&E diagnosis, Wegener's inflammatory process and carcinoma, and the management is totally different. Therefore, it is imperative you go down on the high power, even if there is necrosis, even if there is ulcer slough, and make your look at high power about regarding the cells. CD3 and Eber in situ and Eberish are used to highlight the neoplastic cells and should be applied if nasal lymphoma is suspected and the histological picture alone is not conclusive. So you have to do your thing, but most important is to look at these three differential while you are reporting a nasal mass. Hodgkin lymphoma in extranodal sites, very rare. You should be very cautious in diagnosing a Hodgkin lymphoma in an extranodal site. Although primary GI Hodgkin's lymphoma is a distinct entity, it arises It presents in a broad age range with males more than females. Symptoms mimic exacerbation of IBD, and it is always a classical Hodgkin lymphoma, always EVV positive, and the differential diagnosis is broad again, which is one is non-Hodgkin lymphoma, one is carcinoma, and one is EVV positive mucocutaneous ulcer. Again, you have to look at the total picture, the picture in its totality, that whether other features of NHL or carcinoma or EVV positive mucocutaneous ulcer are present, and diagnose Hodgkin's lymphoma and extranodal sites with extreme caution. So this is a picture. I thank again Professor Judith Ferry for the slides. So this is very dense lymphoid infiltrate within which there is this very nice binuclear cells with prominent eosinophilic nucleoli. These are positive for CD3, CD15 positive for CD15, negative for CD20, and either is positive. So to summarize, always pause and look for subtle lymphoid infiltrates in any biopsy. Look hard within the necrotic and inflammatory infiltrates, particularly in a nasal mass. Careful morphological assessment is needed, complemented by immunophenotypic examination. The initial presentation may be so non-specific that you may not be thinking, the clinician might not be thinking, and you, if you are not aware of the different entities and the modes of presentations, you might not also be thinking. Like a small intestinal perforation, which you might not be. Do cell block for cytology and be aware of the entities. Thank you for a patient hearing. I'd like to thank Dr. Leah Menase, my colleague and consultant at Christie Hospital, for teaching me, and Dr. Professor Judith Ferry of Mass General Hospital. Thank you.
Thank you, Dr. Would you please just start sharing so that we can see you? Yeah, thank you so much. I have, there are quite a few questions from the YouTube which I have shared with you, but if you have your mobile around, then you can see it on the WhatsApp I've sent you, so you can reply to them. Should I read them?
Yeah, I'm able to read it. Yeah, I can see them. Means I think there's a lot of questions regarding this. It might need another lecture to go through all the questions that are there. I would probably do that. In primary cutaneous follicular center lymphoma, what IHC is most important? CD20 is the most important IHC, followed by BCL6, and you also have to do your CD10 and BCL2, because without them you wouldn't be able to diagnose. The problem with this is that BCL2 might be negative, and therefore it's important that you know that BCL2 can be negative in follicular lymphomas, which should not dissuade you from making the diagnosis. And there are other questions are there which will take more time to go through it. We might I might sort of individually go and tell the authors, because I know them on a separate basis.
Yeah, I think. Yeah. I think that's it. So there aren't any questions on the Google Meet. So a wonderful lecture and very nicely presented, especially the concept of dealing with case-wise and then going into the substance of the topic. And I think you have covered almost all of the extranodal gamut of lymphomas at various sites, the usual ones and also the very unusual ones. And my final comment would be in our practice, because we do not go into the depth of immunohistochemistry, is that if you get a lymph node biopsy and if it is very clear cut reactive and you have a history with which supports that it could be reactive, it's best to give it off as reactive. But otherwise, in most of the situations, there is no need to stick your neck out and call for trouble. And best to give a descriptive report and refer it to a higher center which have all the immunohistochemistry markers, because invariably you might burn your finger, and many a times, and most of the times, you'll be surprised to what will come out of it.
Exactly.
It's always better to be very safe with lymph nodes and lymphoid related lesions, whether it is nodal or extranodal. That should be a very important, take home message for people who are working in a slightly compromised, situations where they don't have the access to all the immunohistochemistry. Wonderful lecture, Dr. Debdeep. Very, very nicely done. It opens up your eyes as to what all can happen, especially the cutaneous lesions, which can be really missed out for a very non-specific chronic dermatitis or maybe something very innocuous. Yeah, so one has to know, because it's very, ignorance is bliss. So you may just...
It is better to sign out a case, even if you have the slightest doubt as involved or suspicious of involvement by a lymphoproliferative disorder, and then let the patient go to a higher center where other facilities are available. There is no way one can try to be heroic with your diagnosis, especially in this day and age with all the immunohistochemistry and clonality, to just say this is a mantle cell lymphoma on morphology.
Absolutely right. And that makes this class all the more so important for everybody to see and realize that what all can come out, and one should never be heroic, especially with lymphoid lesions, whether it be a GI lesion or it be a paranasal sinus lesions. You'll be surprised to what all comes out of it. So it's best to be on the safe side.
And that's why I sort of tried to emphasize the clinical presentations, because you, without knowing the clinical, suppose a surgeon goes in the middle of the night with a perforation, resects a segment of a small intestine, it comes to you, it is gangrenous, it is perforated, no other than ulceration and perforation, there is nothing, so you just sort of rule it out as a yeah. But you always have to ask that question: why did it perforate? Why did it do that it did? Means none of the other things are perforating. So not only look at your perforation side, look at your adjacent side to see if there is any pointers to the etiology of perforation.
Exactly, that's right. And many a times we go with our old concept that all perforations are enteric, and these enteric perforations and EATL at times can really put you into trouble. It's always better to know the subject and then be very careful. I mean, people who are heroic are usually the ones who probably don't know what's on the other side.
Exactly.
This class is so relevant, and I hope everybody goes back and listens to it again and again to understand where all one can make mistakes. This is very important class which you have taken, and I thank you so much that you have included almost all the areas which are relevant in extranodal lymphoid lesions, and it is an eye opener for everyone. Thank you so much, Dr. Deb.
Thank you, sir.
Precise. Wonderful. Because I know you are very. We'll discuss that. Right. Till then, thank you so much. Bye bye, everybody. Good night. Take care.